Welcome to Goodfellow Podcasts. This episode is kindly supported by the Royal New Zealand College of General Practitioners, the Auckland faculty. I'm Dr. Louise Kugler, and today I welcome back to the podcast Linda Bryant. Today we are discussing statin therapy in 2023. Linda is a pharmacist prescriber working at Newtown Union Health Service and Porirua Union and Community Health Service. She is an honorary academic in the Department of General Practice and Primary Healthcare at the University of Auckland and has over 20 years' experience teaching postgraduate clinical pharmacy. Hi, Linda, and welcome back to the podcast.
Kia ora, Louise, and thank you so much for this opportunity to chat about statins and the changes that have occurred since I studied them last century. And after 30 years, it's been really great to actually look at my attitude towards statins and my decision-making regarding them. Yeah, somewhat selfishly starting at my age to say, would I take a statin? Would I recommend them to whānau? And if I do, what targets? So great, thanks.
So let's start and put this all into context. So what's happening in New Zealand currently with respect to ischemic heart disease, morbidity and mortality?
Yeah, it's actually really great because, looking at it now, we've made some really massive advances in this. And since 1980, I know that's 40 years ago, but there's been a 60% reduction in the age-adjusted mortality from ischemic heart disease. And although the sort of reduction has slowed down in the sort of last 10 years, and certainly say like the figures we had from Auckland study group from 2005, 2016, the incidence is still reduced by about 30%. So I think that's really great news. Though, I have to admit that we're also seeing the impact of improved technology as well as the medicines therapy. So that rapid response, interventional cardiology with the reperfusion. So now ischemic heart disease is actually the second cause of mortality after cancer. But obviously we can still do a lot more work on this.
Linda, how are we doing in minority populations?
Okay, right. Well, that's perhaps not so good. Unfortunately, we're not succeeding quite so well on that one. While the rate of mortality for Māori is reducing and the gap between Māori and non-Māori is closing somewhat, there's still really clear inequity shown in the mortality rates. So for Māori males compared to a non-Māori male, there's an excess of approximately 40 deaths per 100,000 people. So this is an area we really need to do a lot of work. And although it's not just relating to medicines, obviously, because it's multifactorial issues to address, at the very least, we should be getting the pharmacotherapy sorted for Māori and for our Pacific people.
So you mentioned lots has changed over the last decades, but thinking about cardiovascular risk specifically, what's happening here over the last couple of decades, Linda?
Okay. That does make me feel a bit old because I do remember the 90s, and it was that golden time when statins were really new and exciting and very expensive. So at this time, the concept of cardiovascular risk factors was really great, and being able to estimate the percentage risk of a person having a cardiovascular event in the next 5 years was really great. And it's obviously thanks to Professor Rod Jackson and his team, because that was internationally innovative. And it also coincided with the arrival of these expensive at the time new medicines called statins. And at this time, simvastatin was the sort of leader. And we saw at that time lots of large randomized controlled trials. And I remember being able to reel off like 7 landmark studies with thousands of participants over 5 years with the studies. And there was a lot of debate at that point about the LDL targets and was it absolute value that we aimed for or % reduction, and did the baseline LDL matter? It was pretty much a hotly debated topic throughout the 90s. And so, I should probably also mention that in the studies we talked about, the inclusion criteria was really for secondary prevention or people with a high baseline total cholesterol, LDL cholesterol. It wasn't cardiovascular risk per se. But what we did establish was that irrespective of baseline cholesterol, statins reduced cardiovascular events and mortality. So the question became, when should we start the statins? And so back at that time, perhaps we should just have a little bit reminder about medicines and that the greatest benefit is in those people at greatest risks. And so economically, this meant in terms of cost benefit, we should target and fund those at greatest risk. And remembering at the time that the statins were very expensive. So a quick sort of explanation about that sort of, if we take, and I use 25% because it's easier for me to calculate, if statins reduced mortality by 25%, then a person with a 20% risk of a cardiovascular event would take a statin, and that would reduce that risk down to a quarter, or reduce it a quarter down to 15%, so a 5% absolute risk reduction. And that was really great. We only needed to treat 20 people to prevent one event. But if the risk sort of was down at only 10% for a baseline risk, that 25% risk reduction only brought it down to 7.5%, therefore a 2.5% absolute risk reduction. And for that would need to treat 50 people to prevent a cardiovascular event. And of course, then a 5% risk, we'd have to treat 100 people. So pharmacoeconomically, with expensive medicines, we would target those people at higher risk. But it didn't mean that the medicine itself was ineffective for those at lower risk. But it did mean that back in the 90s, quite a bit after that, the economic decision was that for primary prevention for people with a 15% 5-year cardiovascular risk, they should be encouraged to take a statin. And certainly those people over 20% should be on a statin. But this was a pharmacoeconomic decision, not a clinical one, because obviously statins still reduce the cardiovascular risk basically for all people. But the lower the baseline risk, the more people that we had to treat to get that benefit. And so it was a cost decision. The problem being that 15% has been etched into our brain, I think, or particularly for people who are back then, and we've got this 15%. Then we sort of fast forward to 2018, and Rod Jackson and his team came up with this great new risk calculator specifically for New Zealand. But perhaps even more relevant to that was the fact that statins are much less expensive. And we could just say, cheap as chips, basically. So on a population basis, we should and could use statins in people at a much lower risk, and it's still really cost effective. But then the 2018 guidance, if you think that's already 5 years old, supported that for primary prevention, we should treat people absolutely if their risk was greater than 15% for the 5-year cardiovascular risk, or if their cholesterol is over 8. And then we get to this area who are the people between 5 and 15%. And the recommendation was we should discuss the use of a statin with people and treat in the higher end of the spectrum. So really not very emphatic. And there was a lot more room to move from that action of discussing to actually recommending. And so this is where I found myself floundering somewhat, because people sort of look towards their prescriber to make a decision. And then looking also at that, it's estimated that 74% of people have a cardiovascular risk less than 5%. So that's cool. That's good. But there is 24% of people in that 5 to 14% risk category. And I think these are the people we're under treating to a great extent. And perhaps we're subconsciously waiting for them to reach that 10 to 15% cardiovascular risk that's been a little bit instilled in our brain before we start getting particularly proactive and recommending a statin rather than just discussing. So, sorry, Louise, that was quite a long history, but some of it's been a little bit imprinted on our brain, and we have to go back and reflect on that.
It's wonderful. Thank you, Linda. And yes, quite fascinating doing a journey back in time, and I do remember those days. So thinking in 2023, who we should be considering a statin for, let's break it down into a few categories. So perhaps starting with primary prevention, I suppose. Could you comment on that?
Okay. Primary prevention. Basically, there's a benefit for all people. And as we've discussed, it's a matter of number needed to treat versus number needed to harm. So it came with NICE, who sort of brought out their proposed guidelines, and it's throwing the cat amongst the pigeons, so to speak. Because what they've proposed is that they've lowered the threshold of their 10% cardiovascular risk sort of recommendations. So I've just emphasized there for the NICE, it is 10%. And what they came out with is if you treat 1,000 people with a 10-year cardiovascular risk of 5% for 5 years, about 20 people will not have a cardiovascular event or a stroke. The conversion from a 10-year time period to 5 years is not exactly linear, but if we take that crudely, in New Zealand, that would be a 2.5% risk in 5 years in our terms. And so there would be 10 less cardiovascular events or strokes in that 1,000 people. So still beneficial, but a much higher number needed to treat. Now working in the New Zealand figures, if we take our 5% year risk and we sort of use the nice estimates, then treating someone for 5 years would reduce in 20 less deaths in 1,000 people. And if we take our 10% cutoff risk, then it would be 35 less cardiovascular events or strokes from that 1,000 people. So the benefit's still there. And really the harm from statins is low. The cost is inexpensive. And so we really should be setting our threshold for strong recommendation much lower. And I would be saying certainly in that sort of 6 to 10% range, which is ones that we might be missing. But even more importantly, in the younger people because of the proposed cumulative effect of LDL. So this sort of includes those people with mental health diagnosis because they're usually younger, and especially if they're on an antipsychotic medicine, because it's the effect of the medical condition and the medicines is additive to the cardiovascular risk. And also in our younger Maori and Pacific people. And to some extent, that brings us to the issue of age. If we look at the European guidelines, they enunciate this really well by considering lifetime risk. And that's that the greater the burden of risk factors, the higher the lifetime risk. So there's that sort of accumulation. And so recognizing that we've got limitations in those randomized controlled trials that we had, which really only lasted 5 years. And I think this brings us to the point where we really have to be wary of the younger person with risk factors, but whose cardiovascular risk calculation is relatively low because of their age. And if they look like they've got some isolated risks in there, like LDL, then we perhaps should be looking at that a little bit sooner in terms of starting the statin and targeting those people. I guess that just to continue on the primary prevention, the whole at what point do we stop starting and start stopping the statins? People are living longer, so we're thinking about age now, and it's more difficult and the evidence is not so wildly convincing. Certainly I'd say up to the age of 75, that's worth starting because people are living longer. When we get to 75, it appears there might be a reduction in the risk of myocardial infarction, but less certainty around the mortality. And so this is going to become that conversation to have with people because it's going to be their life expectancy, comorbidities, but also their values and their preferences. So it's a difficult conversation to have when we've got uncertainty around the benefits. And so often you'll find it's going to rely on the person who says, I don't like taking medicines, or I don't want more, or the ones that the concept of having a myocardial infarction or stroke is so bad that they would lower their threshold for when they'd want it. When it comes to people over 80, I think we can probably pretty safely say the decision's a lot easier. A couple of studies have actually shown that lipid profile is poorly correlated to the risk of a major coronary event. So I think we'd be saying that that's a no. And if it comes to stopping, if people have been on it long term, it really reflects the same as above. It's really to do with the person themselves. What's their life expectancy and what do they want? I think it's sometimes very hard stopping a medicine. I'm not a great one for sort of blanket stopping because it has quite a psychological effect on the person. Like, I'm not worth the cost of the medicines and all that sort of thing. It's a difficult conversation. And so I don't think we should be blatantly going out and stopping medicines just because people are of a certain age.
Yeah, some really great points there, Linda. Thank you. So wondering about secondary prevention now and statins. Can you give us some guidance on this?
Oh, I love this one. It's so easy. They have a cardiovascular event, they get a statin. A lot of encouragement that they continue taking that statin. The number needed to treat for 5 years is, if you're going to be using this for people, is like 40 to 80. Interestingly, the number needed to treat was less in the earlier studies, but I think that's because, as I'd mentioned, we've got a lot more interventional cardiology going on there. So that's reduced the risk and hence the NNT might increase a bit, but it's still absolute necessity there. And when it comes to the benefit certainly up to the age of 80. So in this case, if they've had a cardiovascular event, I would not be keen on stopping it at any point unless you are looking at someone who's very frail and perhaps their life expectancy is down to about a year, because the couple of studies, admittedly small, have shown that there is still benefit in reducing the risk of a further event. Those ones are a bit easier than the primary prevention, I think.
Yes. What about other special conditions, Linda, say familial hypercholesterolemia? What would you advise here?
Yeah, I think perhaps we're sort of underestimating or under-recognising that, because I think it's a genetic problem, obviously, because it's familial, and it can account for up to about a third of people with ischemic heart disease. So it's an important one to recognise. And if we look particularly in young people, if they've got a total cholesterol greater than 5.5, and perhaps older people if it's above 9, if their LDL's over 5, or if their triglycerides are over 20, and I must admit, I've seen some with triglycerides at 23, if you've excluded the excess alcohol or the high blood glucose for the triglycerides, then you should really be sort of perhaps thinking about familial hypercholesterolemia. You could probably include family history in there as well. There is a easy to find Dutch Lipid Clinic network score, and that will give you a score of whether it's sort of definite, probable or possible to have familial hypercholesterolemia. And there is a genetic test available. So I think every lab would do it, just to be aware though that you need to get special permission from the person, and they have to sign on that because obviously it is a DNA check. And we are very conscious about, genetics and genetic information and what's done with that. But you can get a genetic test. And what does it mean? Obviously, you were going to treat the person anyway because of their lipid profile. But it does mean that you can get to the other family members, particularly the children, a lot earlier with treatment, and recognise that we don't use the cardiovascular risk calculator in these people. Just because of age, it's going to come low. So it's quite helpful. I do think about it when I've got people who've got these very high values of total cholesterol and of triglycerides.
Yeah, that's a great point and a reminder about not using the standard scores for these people. So thank you for highlighting that one. Linda, any other conditions we should think about or people that we should be considering a statin for?
I think mainly it is looking at those ones who, obviously, the mental health group of people. And I know there's debates about the dose equitype and as to whether we should check it, but I think they have to be looked at. Māori and Pacific in particular, and our Indian population, because they're at high risk. I think, I tend to be very wary about the people with LDL, high LDL concentrations. And because of this accumulation, it's sort of a bit like the HbA1c. I put a little bit of a criteria that when people are getting certainly over 3.5, I would start thinking about treatment. And I reflect back then on the studies as well that were earlier on, where that was some of the inclusion criteria was merely having an LDL of 3.4 or more. So I tend to be lowering my threshold when I see those LDL concentrations getting up there on those. We're changing our mind about LDL.
Yes, yeah, there's definitely movement in that space, isn't there? So let's discuss targets for a moment. You've mentioned LDL, so let's continue on with that. So what should we be aiming for with an LDL level nowadays?
Yeah, you're right. This is probably the area where it's been the biggest changes. Like how low should we go? Should it be a percentage change? And I notice that it's a bit conflicting. If we think we get a trigger for our using a statin by using a total cholesterol to HDL ratio, and then we have a target of LDL, but in one case it's a percent reduction and in the other case it's an absolute value. So it does look a little bit crazy and a bit of a quagmire. So how low should we go? Should it be percentage? That's sort of on our primary versus secondary prevention. Is it just a surrogate marker? So it's really interesting. For a couple of decades now, we've had this debate. Is it the pleiotropic effects that, statins are actually anti-inflammatory and the stabilization of plaque? Or is it we really need to get the LDL down, and we haven't had a chance before to do that. And the next one that sort of comes in around that is, are we talking about plaque stabilization or even plaque regression? So we know that there's advantages in the LDL, and we've also noticed in other conditions like asthma, not that we're going to use statins to treat asthma, but they have found there's a lot of anti-inflammatory effects, and it reduces the interleukins and things like that, various interleukins. So it could well be we've got both mechanisms working. There's an anti-inflammatory, iotropic effect going on, but also the LDL lowering specifically is also very important, even though it may not be the whole story. So since we've had more potent statins available, and for that I'm thinking about rosuvastatin, and we've got the new medicines overseas, which are the monoclonal antibodies, the evolocumab and the alirocumab, that these ones reduce LDL by about 50%. So that means that we've had more ability to see what happens when we get the LDL down really, really low, and whether that has an effect on events. So it's quite interesting to see that in the, we're sort of changing our mind a bit, because in the New Zealand guidance for secondary prevention, our 2018 version, the LDL target for secondary prevention is less than 1.8 millimoles per litre. Yet we look at the 2021 Society of Australasian Cardiologists, and the target down there is right at less than 1.4 millimoles per litre. And that's very much in line with the European recommendations. So it sort of raises the issue of reducing plaque regression, whether we're just reducing it, the progression, whether we're getting plaque stabilization, or even whether we can get the plaque regression. And there's been some big studies that have come out, the asteroid reversal, even early on the TNT studies, indicating that plaque regression is actually possible, and we can get reduced plaque volume, improved stability of the fibrous cap. And in fact, this does reduce our risk of a cardiovascular event as well, and it's safe. So I know it seems a little bit arbitrary at times, but pretty much it's shown that LDL less than 1.55 millimoles per litre can reduce plaque in 18 to 24 months. So that's a real positive. And we can get stabilization even when LDL is greater than 1.5 millimoles per litre above that. But I'd still say that you'd want it below 2. So I think LDL sort of focusing is where we're getting down to, would be that long-term high LDL is damaging. We should check that, lower our threshold, and we should be getting it down at least 50% from baseline, or in the high-risk people to less than 1.8%, which is in line with the European guidelines for primary prevention, whichever is lower. And so I think we just need to target the LDL a lot more. And as I said, when it comes to the concentrations at baseline, above 3.4 for sure, I would be raising red flags and thinking about starting a statin at that point as well.
Be interesting to see what happens when we next update our guidelines to see where that lands, Linda.
I'm actually looking forward to it. And I do think there'll be lots of changes. We'll be talking about medicines, but one of the things is it's very hard to have low targets when we don't necessarily have the medicines to get us there.
Yes.
So we shouldn't be scared of atorvastatin 80 milligrams. I used to be, oh no, what's the point of 80 milligrams atorvastatin? But having gone through this sort of revision, I am no longer scared of the atorvastatin 80 milligrams, because I do think getting the LDL down is so important.
So Linda, we've talked about LDL. I wonder if we can just touch on ratios and cardiovascular risk as far as targets go.
Yeah, so as I said, it's really interesting that the ratios is what's our trigger almost, since we've put that into our cardiovascular risk calculation. And then we tend to just ignore it and we just focus on LDL. So I don't think too much of a target. The thing that's come up, though, relating to that target, when we put it in the calculator, is there seems to be a U curve around the HDL. So running around thinking, oh, wow, I've got really good HDL of 2.5 or something, and therefore my total cholesterol doesn't really matter because the ratio is low. I think we're finding that U-shaped curve, that having HDL above 2 is probably not quite such a good idea. It's not as protective as we may have thought initially. So that becomes sort of one of the things to look at. So while I use the ratio there in the calculation, I don't tend to focus on it other than that, but I am wary about high HDL. When it comes to the cardiovascular risk, it's really difficult because obviously people are going to be clinically high, above 15%, having had an event, but it's still important to look at how low we can get their calculated risk. So it's how much their lifestyles had an impact, and getting their cardiovascular risk down by getting their ratio down when we put it in. But I think we have to acknowledge that calculation is for primary prevention, and it's not such a good thing for secondary prevention. It's just sort of a bit of an indicator to tell the patient that they're doing well because their calculated risk has gone down. Yeah, as I said, I just try and get their cholesterol down, and I shouldn't be so totally focused on cholesterol. Remember, we have to get their blood pressure down as well, but that's a separate talk. So it is the holistic approach that we take to people.
Yes, absolutely. Linda, thinking about empowering our patients to make decisions, and you discussed earlier about having discussions versus making recommendations. I wonder what tools you use to highlight benefits. Do you have any ones that you would use in a clinic setting that would highlight these things?
It's always interesting how people perceive risk, but it's also what motivates people or pushes their buttons to take preventive medicine. And I think we all find that this is sometimes the bane of our lives, is the sort of preventive medicine thing. So I usually find that, first of all, it's really helpful to do the 30 to 60 second explanation that I've developed on what a myocardial infarction or a stroke actually is, by linking the risk factors of cholesterol, blood pressure, and thrombosis, what it is. And I actually try to get the person engaged by, I'm not a good artist, but I do try and do a little picture. And it's showing the sort of smooth stainless steel pipes when people are 20 years old and how they progress to rusty old pipes by the time we're getting a lot older. And the build-up of gunge, the fatty streaks that cause the narrowing of the pipes, and we therefore have a high pressure pipe, and that's our blood pressure. And then the concept of this being high blood pressure and bursting open the fatty streaks that are made up with cholesterol, and then the formation of a blood clot. And this seems to draw people in. So the first thing really is we can look at a whole lot of risks, but most people are quite visual. So the idea of why we use multiple medicines, because that's another issue for people, is this is a holistic approach, and these are the things we're looking at. And then I tend to find people respond quite well to numbers needed to treat concept. Pretty sure the epidemiologists don't like the numbers needed to treat, but people can relate to it. If we treat 30 people just like you, then one less person's going to have a heart attack or stroke. And this looks pretty good in numbers to the person. So I'll often do that, and I can do a quick and ready one if I use the PMS cardiovascular risk calculator. Normally it's the BPAC one. You can get a risk and you do a quick calculation of number needed to treat. But I also find I usually have at the bottom of my toolbar the absolute cardiovascular risk calculator. And this is the McMaster one, the predict with smiley faces. And I find that's really useful visually for some people. The thing I would say is remember to click on the top right predict button, because the others are 10-year risks and it's absolutely horrifying. So basically I use that, and people do like the smiley faces and they can see a benefit, and you can talk about number needed to treat. Obviously, if you're in a very busy consultation, it can take a bit more time, but can be worth it. The NICE have a very large patient aid PDF document. I find it a bit long and a little bit complicated, so I don't tend to use that. The other one is the New Zealand Heart Foundation one, and that's really interesting. Unfortunately, it's not embedded in the PMS, so you've got to go to it, and it's know your age, and this takes quite a different perspective. And I do tend to calculate the heart age before I see the person on this, because some people seeing that their heart age is 71 when they're only 60, that can be really off-putting. But I think it's really quite an important one for people who are younger. And this is because we talked, as I said, with the European guidelines that they have, is talking about the lifetime risk for younger people. and lowering our threshold for treating younger people. So yeah, that one I think is quite good by giving the lifetime risk, and it's visual, but just be careful about that concept of, you don't want to make people feel really put off on that.
Absolutely. I've noticed that too. So Linda, thinking about starting a statin now, what statins do you tend to choose first and why? And then how do you titrate?
Strangely enough, we're very limited in what statin we can choose. So I tend to go for a atorvastatin. And the sort of thing, my usual philosophy is the start low, go slow. But then there's always the risk of clinical inertia because you've started and we continue with other things. Or the person comes back and they think they might have failed because you're going to come in the next time and say, oh, good, you've tolerated that. Let's increase the dose. So I usually bear in mind the sort of person's attitude to medicines and whether there are some people, be it genetically or whatever, but they're prone to adverse effects to a number of medicines. So if possible, I've tended to jump in with atorvastatin 40 milligrams for those people that say they're at higher risk when we've calculated the cardiovascular risk, or they have an LDL above 3, and for people under 65. So I've tended to jump in there with that. I would like to use rosuvastatin, but we've got some restrictions on that as well. So that limits our choice completely. I tend not to use simvastatin anymore. I think that's where we had a lot of problems early on with the muscle aches. And pravastatin, sort of if people have muscle aches, I might try pravastatin because it's water soluble. But we tend to have quite a limited choice, unfortunately, at the moment. And as I said, I want to get their doses up. Now, if you're going to treat with the LDL in mind and with a low LDL in mind. So I'm tending to not use atorvastatin 10 milligrams just to give a little dribble to see how it goes. That's probably not very effective at all.
Linda, you've mentioned muscle aches and the reasons for starting lower. They seem to be less of a thing now. So I'm interested in your comment around that. But your patient does return to you complaining that they do have muscle aches and wonder if they are intolerant. So what do you do now?
This muscle ache thing's been quite debated in the cholesterol treatment trialist collaboration, who are very into using cholesterol lowering agents. Sort of estimate that 11 cases of muscle aches per 1,000 person years. So they're sort of thinking it's a low risk. But if muscle aches occur, then they're definitely affecting the person. We're not going to deny that. And certainly another study showed that 50% with well-documented statin tolerance truly have an intolerance. So we can't ignore that. And also, again, looking at the genetic issues, there is a genetic rationale for people getting muscle aches. So it becomes a bit of a problem. The risk factors obviously are people who are over 75 years old, which is why I wouldn't jump in for those over 65. That's why I wouldn't jump in with a high dose of atorvastatin. Being female, frailty, and then history of other muscle disorders, impaired renal function, or family history. That's the genetic thing. So you'd consider the risk factors. NICE do have a very complex statin intolerance pathway, so just picking out the bits from that one. First thing is that you'd sort of look at check the TSH to see if it's a thyroid problem. Obviously see the C-reactive protein, look at the CK. And if your local lab allows you to do this, in some places they don't, check the vitamin D, remembering that probably about 50% of people in New Zealand are a bit deficient of vitamin D. But certainly if you're looking at Māori and Pacific or people with a darker skin pigmentation, check that would be the first thing. Also, find out if they suddenly had an increase in physical activity because you've talked to them about lifestyle changes. You might consider polymyalgia rheumatica, probably not so much, but always worth bearing in mind. And probably one of the main things would be saying is that it is not due to a deficiency of coenzyme Q10 depletion, so supplementation will not help. So when you've sort of looked at those, if the people wanted to try it for another 6 weeks, then you could see whether it was one of those temporary things and it's just coincidental. But I find people are not very amenable to that. They've looked up the internet and they've seen what muscle aches is a problem. So the idea would be to stop the statin. You could re-challenge at a lower dose in 5 to 6 weeks, but again, people aren't that keen to go back on the same medicine. So, it's wishful thinking. So that's where I would trial pravastatin because it is water-soluble, but it is less potent, so you're not going to get such a good response. And if the person does qualify for rosuvastatin, I would jump in right there. The special authority criteria are really tight at the moment, and I'd certainly be hoping they're going to loosen them up and they'll be available. I'm really lucky because I deal with a lot for Māori and Pacific people, and so we can automatically switch or use the rosuvastatin. Why is it better? It seems to have less muscle aches, but it's also more potent. So if we're going to be focusing on getting that LDL down, as we've talked about, then using a more potent statin is going to be really relevant. Yeah, it is hard. It's a bit of a heart sink, but I haven't had people come in telling me about muscle aches for a long time. I've had more people when I've wanted to start a statin and, back in 2012, I got muscle aches, and you have a look and it was due to simvastatin, but it's still a difficult conversation to convince them to try another one.
Absolutely. So when somebody refuses to go onto a statin again, or the statin is thought to be the problem, what other options have we got in New Zealand at the moment?
Okay, unfortunately, we're not really awash with multitude of funded options, but ezetimibe is available. It's okay. People are recommending it to get that extra kick once you're on a statin, added in to get that LDL down to what we're thinking of targets. But it really is about 50% less effective than statins at lowering LDL. It's an additive one. But if you can't use much else, then definitely go for that. I think we can basically discount the fibrates. The benefit is just not really there. It's not proven at all. So I've tended not to even contemplate that now. Even in the old days, we might have. Hopefully soon we're going to get the PCSK9 inhibitors. That's the one you sort of mentioned, the iloocumab, which are 4 weekly subcut injections. So even better with that because they can do it themselves. So, in this case, just a bit of explanation. The PCSK9 enzyme degrades the LDL receptors, and therefore it means that there's going to be more LDL circulating. And this is actually a genetic polymorphism, which is what would be handy in the future we can look at. And so the monoclonal antibodies inhibit that enzyme, and hence they increase the LDL receptors, reduce the free LDL. And I would just love to be able to do a genetic test for a lot of our people with high LDL, and then use this as a way of getting a special authority for this medicine. They're commonly used overseas. They are expensive because they're monoclonal antibodies, but I think they'll be well worth it. And I'd be hoping to see those soon. The other medicine I've seen advertised in a newspaper, but strangely enough, I don't think it's actually licensed in New Zealand. And that's bempedoic acid. And this is one it's a bit of an upstream, it acts upstream to where the statins work, but you only get a modest reduction in LDL, about halfway between the ezetimibe and the statins. And there is only really one large study that's shown great sort of benefit and outcomes. The interesting thing was that the benefit was greater than what they'd expect from LDL lowering by itself. So there is, that other action that might be happening. But I wouldn't be jumping on that necessarily in New Zealand, because for every 100 people treated, one person got gout. And I think New Zealand's a bit like the gout capital of the world. So it might not be such a good idea for New Zealand. So it gives us a pretty limited range of medicines to use at the moment. I'm reasonably confident, though, that Pharmac will see that we do need options on that.
Thank you, Linda. So thinking about genetics, which you touched on earlier, is this something that we should be considering in primary care in the community? And if so, how do we explore this?
Yeah, for the primary care, I think this is going to become a lot more relevant, certainly in the next sort of 5 years or so, because it's expanding. And there's a lot of things happening, and I don't know if anyone has sort of people that come in and say, I went and did one of those direct-to-consumer genetic tests, and they say my polygenic risk of a cardiovascular disease is really high or something. So you can see that it is going to be coming in as an issue. But what we're finding is that even if we reduce the LDL, there's still some remnant cardiovascular risk there. And so this is going to be an area that's being investigated, and particularly the atherogenic lipoproteins like lipoprotein A that's happening. And this is a lipoprotein that's pretty much under genetic control of apolipoprotein A. And the variation in this gene accounts for something like 91% of the variation in lipoprotein A. And these variations are associated with cardiovascular events, and it's independent of LDL lowering. What you find is this association, it's highly associated with high triglycerides, low HDL, obesity and insulin resistant. So it's an area of treatment that I think we can be looking forward to seeing a lot more happening, and especially for our people with diabetes. But it is that genetic issue. We've talked about the CPSK9 enzyme, and that this is also a genetic issue that hopefully if we could find this, you can tell I'm really hoping that we get a better ability to do genetic arrays or panels to be able to identify people and really target treatment to them with specific medicines. As a pharmacist, I'm also keen on the genetic polymorphisms that relate to the effectiveness of statins. So there's things like the SLCO1B1, it's like alphabet city out there, but they're gene variants. And they're going to help tell us whether the statins are going to be more effective, less effective, whether we're going to be more susceptible to muscle aches. And so I think we haven't quite sort of got the clinical relevance on this yet because we don't have ready access to the testing. But I think the clinical application will be more evident in a few years. So genetically, obviously, cardiovascular disease is a polygenetic condition, but people are plucking away at those. And perhaps in the future, we'll also be looking at being able to change gene expression, which is happening with some of the other genetic treatments that people are looking at, is changing the gene expression. So, yeah, I think there's quite a lot to do with genetics, not the be-all and end-all, obviously. There are still lifestyle things to do with changing, epigenetics. But coming in the next 5 years, maybe 10 years, there'll be a lot of different treatment. And it will be primary care that's actually doing these treatments.
Oh, that's fascinating, Linda. So we've got genetics and perhaps some new medications. Is there anything else that we should be watching out for in the next few years?
Hopefully better clarity on what we're actually targeting, if we're targeting things like LDL. But I think they'll be using the monoclonal antibodies, almost jumping straight from that, though, to using the genetics to try and develop treatments. As I said, it's quite a different area. I think epigenetics will be one thing which we can deal with, in that lifestyle can change our expression of genes. And they have shown for sure that that's a major issue. So maybe while I'm focusing on the medicines and we're talking about treatment, overall, I don't think we should neglect the lifestyle and the epigenetics that goes with that actually reduces our risk. It's not just a matter of losing weight and things like that. It does have a big impact on how our genes are expressed. So maybe I like medicines, but we should not forget about the lifestyle changes that are really important.
Absolutely. Well, thank you so much for your time today, Linda. It's been an absolute pleasure as always. I wonder, as we conclude our podcast, do you have any take-home messages, please, for our listeners?
Review your approach to cardiovascular risk. Like I had to look at my approach and what I was doing, and consider lowering your threshold to recommending and initiating statins, particularly in the young people who have got risk factors, even if they're not coming up really high on the cardiovascular risk. Think about those people when they're younger with a cardiovascular risk, maybe sort of in the 6 to 10% as well, and include that high LDL concentration as a little bit of a red flag. Although it's not in randomized controlled trials, there's certainly good evidence that lowering LDL is the key. So lowering it down to at least down to 1.4 millimoles per litre for secondary prevention, and for the high risk primary prevention, getting it down to 1.8 is going to be really important. In general, I'm really trying to think below 2 looks good to me. Whether it's due to the pleiotropic effects or the LDL concentration itself, if you're going to treat, then treat definitely. Don't be scared of the atorvastatin. 80 cardiologists will love the fact that we're saying that. use rosuvastatin if you can, because that's really potent and that's going to help get down there. But I think we're past now the stage where it's, let's give you a little bit dribble, a atorvastatin, 10 milligrams or something, and see if it's going to work. Just get in there and treat. Explain to the person how cholesterol's involved in causing a myocardial infarction or stroke, and then use number needed to treat, smiley faces, or the absolute cardiovascular risk calculator or heart age, whatever it is that's going to engage the people. They're simple and can be really brief, but it's still okay because it engages the person. And I guess the last thing is that there are more medicines out there and we need them. And hopefully they're going to be available soon. So, thanks, Louise.
Wonderful. Thanks, Linda. It's been a pleasure. If you're a New Zealand GP, please log this podcast for your CPD points, and you'll find a list of resources we've used in making this podcast on our website, goodfellowunit.org. Thank you for listening.